Today, hello everyone. Um, Today we'll be going through occipital condyle fractures, a bit about what they are, um, diagnosis, and treatment options. So, the occipital condyle fracture, as you can see, is a fracture that occurs over the occipital condyle. It was first described in 1817 by Bell. It's quite rare actually, with a very low incidence. So usually it's quite traumatic in nature. So when there's blunt force trauma, we should be very highly suspective of it. Other things that we can consider based on the clinical situation is if there's any cranial cervical injury. So it's usually quite there's a lot of association with other cervical spine injuries. Altered level of consciousness, if the patient has any occipital pain, if they're very limited cervical movement, presence of any cranial nerve palsies, especially post-trauma, and any retropharyngeal soft tissue swelling. Now, we'll start with some classification. So the Anderson Montesano classification is the most common one that's always been described as. It's really based on craniocervical misalignment, that's spelled wrongly, sorry, that's present or absent on the CT scan. And it's can be measured with the occipital condyle to the C1 interval being more than 2 millimeters in size. So we've got type 1, type 2, and type 3. So A and B demonstrates type 1, where you can see that there's a fracture of the occipital condyle over here, while type 2 describes a linear extension. And then type 3 describes an avulsion fracture involving the condyle piece, as you can see more easily demonstrated on the F image. So why we classify them? Well, it really dictates what treatment approach we have. So when we think about treatments, they say it's controversial because of whether there's rigid collars or halo vests, but we'll talk through them. So I guess the reason why we treat occipital condyle fractures is that we see that in untreated cases, there can be the development of lower cranial nerve palsies and deficits. So type 1 and type 2, as we described before, are usually treated with or without external immobilization, without any obvious differences in terms of outcomes. In terms of external mobilization, you can treat them in usually a rigid hard collar like this, or when we want more definitive fixation or limited movement of the neck, we can install a halo device, which includes screws into the actual skull and which is locked into place with a vest that the patient wears. Type 3 should be treated with external immobilization. Now, there are certain situations where things can be a little bit different. So, for example, if there's any associated atlanto-occipital ligamentous injury or any instability that's been noted, then we should consider a halo vest or surgery in the form of fusion, because it's a higher risk. If there's bilateral occipital condyle injuries, then you should consider halo immobilization. And in terms of outcomes, there's a study that looked at 100 patients with occipital condyle fractures where three underwent fusion because of craniocervical misalignment or other C1-2 fractures. And the remainder of the patients, 97 of them, were treated with just rigid collars. And none of them developed neurological deficits or delayed instability after follow-up period. And this picture on the right just shows a form of an occipital cranial occipital fusion. Sorry, occipital cervical fusion. So that sort of summarizes occipital condyle fractures. I look forward to making more videos, just shorter pace, so it has a little bit of a summary. bite-sized information. Just comment down below on what you want to hear next and stay tuned. Thanks for listening.